Hi everyone, my name is Med2Med. Today's video is going to be about a condition called hereditary hemochromatosis. These notes are based on the following resources. I've been using Zero to Finals, the PDF on scotsnotes.co.uk, the Oxford Handbook of Clinical Medicine, and the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. Haemochromatosis is a disorder all to do with iron, but not this type of iron, this type of iron. In this condition, there is increased iron absorption in the intestines, so iron deposits everywhere, in the joints, the liver, the heart, the pancreas, pretty much everywhere. As this is an inherited disorder, genes play an important role in our understanding of the disease. The human hemochromatosis protein, or HFE gene, is located on chromosome 6, and most causes of hemochromatosis are related to a mutation of this gene. The two most common mutations are C282Y and H63D. Usually in men, the disease presents around the age of 40, but in women, it may present later because of the effect of menstruation eliminating iron from the body. Let's look at some of the signs and symptoms of hereditary hemochromatosis in our patients. Firstly, they may be chronically fatigued or tired in the early stages of the disease. They may also have arthralgia, which is joint pain, typically in the MCP and knee joints. Their skin may develop a bronze tinge to it. They may complain of hair loss, erectile dysfunction in men, and in women a lack of periods, so that's amenorrhea, due to poor production of gonadotrophins. So we know that iron is also deposited in the pituitary gland. They may develop cognitive symptoms and features of chronic liver disease like hepatomegaly and cirrhosis. When we investigate hemochromatosis, we look at the ferritin levels. This is a protein which stores iron within the body, so if there is too much iron, less is released, and if there is too little, then more will be released. So this is what we call a buffer. Because of this, it's an important diagnostic marker in iron deficiency anemia, as well as in hemochromatosis. But it isn't just raised in hemochromatosis, as it is what we call an acute phase reactant, which means it also increases in inflammatory conditions. But what does this mean for us as diagnosticians? Well, it means that the results aren't always clear. It can be raised in iron overload, so that's what's occurring in hemochromatosis, or in these inflammatory processes. Now, because of this, you need to use ferritin in conjunction with another protein called transferrin. This is a glycoprotein which controls the transport of iron. If both ferritin and transferrin are raised, then you know that iron is being mobilized a lot, and this signifies iron overload. If the transferrin is normal, then the rise in ferritin is probably just an acute phase response. Now that you know there's an issue with iron overload, you should carry out genetic testing to confirm hemochromatosis. The gold standard test for diagnosing this condition used to be a liver biopsy with Pearl stain, which would react with the iron and show up blue in the parenchymal cells. But genetic testing is now used instead, but this test is still useful to assess the severity of the condition. Okay, let's put that all together. A diagnosis of hereditary hemochromatosis is made by results showing a raised serum ferritin and transferrin level, a positive genetic test. Pearl staining can quantify the degree of iron loading. CT can show attenuation of the liver, which is visible as darkening. And lastly, MRI can show the liver and cardiac effects caused by iron deposition. All of the complications associated with hemochromatosis are all to do with where the iron deposits occur. If they're found within the pancreas, type 1 diabetes might develop. Where there is deposition in the liver, the patient may become cirrhotic. As we've spoken about, pituitary, gonad and endocrine function leads to sexual difficulties like hypergonadism, amenorrhea in women, and erectile dysfunction in men. Lastly, where there are cardiac deposits, cardiomyopathy, which is disease of the heart muscle, can occur. Cancer of the liver can occur too. Thyroid deposits may lead to hypothyroidism, and calcium deposits can occur in the joints, which is called chondrocalcinosis, causing arthritis. So obviously recognising this condition and managing the complications is really important, so let's go through the treatment of this condition. No, unfortunately the treatment isn't vampirism, but the principle is similar. It's called venesection, and it is the process of removing blood every week to decrease the total iron. The other important step is to essentially sit and wait. You need to monitor the patient over time with their serum ferritin levels and the risk of any complications. Of course, if the patients do develop complications, for instance hypothyroidism, then you need to treat each condition appropriately. So whilst venesection is an important part of the treatment process, treat your patient holistically, looking at each interlinking system, and make sure that any complications are recognised and treated early. I hope that all made sense. I think this is quite a nice logical condition where the symptoms, although really varied, make logical sense. So let's recap. Hereditary hemochromatosis is a genetic disorder which causes excessive total body iron which is deposited into the tissues. The majority of cases are related to mutations to the human hemochromatosis protein gene. The patients may present as tired, with joint pain, bronze pigmentation of the skin, hair loss, erectile dysfunction, and amenorrhea. Potentially cognitive decline can occur as well. Typically, male patients present in their 40s, but due to the purging effect of menstruation, women remove iron easier than men and may present at a later date. In order to diagnose hereditary hemochromatosis, serum ferritin and transferrin levels will be raised, which indicates the need for a genetic test to confirm the diagnosis. However, raised serum ferritin levels on their own don't always indicate hemochromatosis, as it is what we call an acute phase reactant, and is raised in these inflammatory conditions as well, which is why transferrin levels are so important. It used to be diagnosed via Pearl stain, which dyes iron blue within the cells. You can also use CT to see if there's any attenuation of the liver, and MRI can show iron deposits elsewhere in the body. Lastly, to treat this condition, you must remove iron from the body, which is done via venesection, but you mustn't neglect signs of iron deposits elsewhere in the body, so monitoring the patients for other complications regularly is crucial. This video was brought to you by Med2Med. If you enjoyed today's video, please like, comment and subscribe, and I'll see you next time.